small gestational age, and postpartum hemorrhage. Thus, it effect on pregnancy. Now, how we will diagnose a adenomyotic patient? We can diagnose the adenomyotic as a whole clinical and then symptom and sign, and there will be some test and this as a whole will produce the diagnosis. That is, clinical diagnosis is difficult due to non-specific nature of sign and symptoms. There is no specific nature of sign symptom. That's why only clinical diagnosis is difficult. There is needed a combination of modalities required to reach in confirmed diagnosis. Okay, we will see the modalities of diagnosis. There may be presence of invasive and non-invasive protocol for diagnosis of adenomyosis. In case of non-invasive, that is imaging, and imaging include transvaginal sonography and MRI. In case of invasive, that may be laparoscopic guided histopathology, and histopathology is the gold standard diagnostic protocol for adenomyosis, but it is also a invasive and that is difficult procedure that is not commonly done. It is only done after surgical intervention. This whole non-invasive and invasive can give you the confirmed diagnosis of adenomyosis. Now, the ultrasonographic finding. We can use 2D ultrasonography and 3D ultrasonography. We can do the 2D and 3D ultrasonography to diagnose adenomyosis. First line investigation is 2D ultrasonography, but it fails to provide sufficient image resolution for visualization of myometrium. So we can do the TVS ultrasound with the color Doppler that improve better imaging of junctional junction. Okay, there is a criteria that is MOSA. MOSA denotes for morphological uterus sonographic assessment. There is 9 feature that we can find in the TVS sonography, and this produce the diagnostic of adenomyosis. First of all, there is asymmetrical thickening of the myometrium. What happened? This is the anterior part of myometrium. This is the posterior part of myometrium. In case of adenomyosis, there is globular shape of the uterus occur. There is generalized increase the size and shape of the uterus, and there is also produced asymmetrical thickening. That is, maybe there is a increased thickness of the posterior wall of the myometrium than the anterior, or vice versa occur, and there is asymmetrical thickening. Second criteria is there is presence of myometrial cyst, collection of fluid into the myometrial, that is known as cyst. There may be presence of myometrial cyst into the myometrium. Then third criteria is hyperechoic island. There may be presence of hyperechogenic structure, adenomyotic foci into the myometrium, that is hyperechoic island is present into the myometrium. The fourth criteria is there is fan-shaped shadowing that is found into the TVS sonography. Then hyperechoic subendometrial lines and bars. There may be presence of echogenic structure into the subendometrial layer and present as subendometrial lines and bud. Next ones, if we give the color Doppler, we can find the translational vascularity around the adenomyotic tissue. Okay, if we see the junctional zone, we can find the irregular junctional zone. There may be no continuity of the junctional zone, there presence of irregularity into the junctional zone. Then we can find the interrupted or ill-defined junctional zone, that one side is complete and there is maybe gap, there may be gap present into the junctional zone. This is the overall mosaic criteria for assessment of adenomyosis in sonography. Okay, this is some figure that's showing the transvaginal sonographic findings of adenomyosis. In case of first figure, we are seeing that there is collection of fluid into the myometrium. These are the myometrial cyst. In second feature, there is sun ray appearance is present, and the feature of the adenomyosis. And we also see the abnormal thickening of the myometrium. This is the posterior wall and this is the anterior wall, and thickness increased in the posterior wall more than the anterior wall. It is asymmetrical thickening of the wall of the myometrium in case of adenomyosis. In third figure, there is posterior bulging present. It is the another feature of adenomyosis in case of TBS finding. And there is presence of focal adenomyotic tissue into the myometrium. This is the another feature of adenomyosis we can find in the transvaginal sonography. Okay, this is the color Doppler. If we give the color flow into the adenomyotic lesion, we will show the increased vascularity of translational vascularity. This is the adenomyotic tissue, and that is the increase of translational vascularity in case of color Doppler in adenomyosis disease. This is also same increased vascularity into the color Doppler. Now the TVS ultrasonography, the showing we previously called it is better understand the junctional zone. There is increased thickness of junctional zone. This is the endometrium and this is the myometrium, and there is increased thickness of junctional zone. It is also the figure of junctional zone. Now the most important diagnostic tool for adenomyosis, this is MRI, magnetic resonance imaging. What are the criteria we found in case of adenomyotic patient in MRI? First of all, a myometrial mass with indistinct margin of primarily low signal intensity. Then we can find diffuse or local widening of junctional zone on T2 image. Thickening of junctional zone is more than 12 mm or irregular junctional thickness with a difference of more than 5 mm between the maximum thickness and minimum thickness. And ill-defined area of low signal intensity in the myometrium is found in T2 image. Islands of ectopic myometrial tissue identified as punctate foci of high signal intensity on T1 image. We can also find Swiss cheese appearance with exuberant myometrial cyst and nodule on contrast enhanced T2 image. Now we will see it from the MRI slides. That is the in figure A and B. It showed the thickened junctional zone. This is the figure A and B. This showing the thickened junctional zone. In figure C, there is presence of foci of adenomyotic lesion into the myometrium. And in figure D, it is present asymmetrical thickening of the myometrium. Okay. In this figure, we can see that the Swiss cheese appearance into the myometrium. This is the diagnostic criteria in MRI that is we found into the adenomyotic patient. There are other modalities, but these are the absolute help in aiding diagnosis. These are the we will discuss later. Now the histological examination. There is a presence of endometrial tissue more than 2.5 millimeter below the endometrial junction. It is the diagnostic criteria in the histopathological slide. Junctional thickness, zone thickness is more than 12 millimeter. Okay, from figure we see that it is a histological slide made after operation, and it is the endometrial layer contain normal endometrial stroma and gland. These whole are the myometrium containing muscle layer of the uterus, and there is presence of ectopic endometrial gland and stroma into the myometrial layer. And for diagnosis, what we learned from previous slide, that junctional zone thickness will be more than 12 millimeter and presence of endometrial tissue below the 2.5 millimeter. Okay, this is the endometrium and presence, this distance will be 2.5 millimeter and thickness in this area will be junctional zone, that is overlying the endometrium, the layer of inner myometrium. This thickness will be junctional zone thickness J. That junctional zone thickness will be more than 12 millimeter. These are the diagnostic criteria of adenomyosis in histopathological examination. What are the other modalities? These are the now obsolete, but it helps in aiding diagnosis, but we are not use this nowadays. These are the hysterosalpingography, hysteroscopy, and elastography. This first figure showing the hysterosalpingography diagram. This is showing the hysteroscopic figure, and these are the elastography. Okay, what we found into the hysterosalpingography, this is the uterine cavity, and there is outpouching of the contrast producing like diverticulum. These are the feature of adenomyosis into the hysterosalpingographic film. Okay, now the second one is hysteroscopy. What we found into the hysteroscopy, we see the strawberry appearance of the endometrium. Strawberry appearance of the endometrium is found into the hysteroscopy in case of adenomyosis. Then there maybe we can found hypervascularization of the endometrium, then cystic hemorrhagic changes into the endometrium, and endometrial defect. These are the criteria of adenomyosis in case of hysteroscopy. Now the another modality that is elastography. What is elastography? Elastography is the modalities of diagnostic tool that see the properties and stiffness of the soft tissue. If we see the color flow, then in case of cystic, there will be presence of green and blue color, and in case of firm tissue, there will be produced only blue color. In case of adenomyosis, in elastography, we see the green and blue color that denotes the cystic changes into the myometrium due to collection of fluid into the glandular tissue and stroma of the endometrium. And in contrast, or the other hand, in case of fibroid, that is changes into the firm, not cystic. So in elastography, we will find there is changes into the color blue. This is the differences of fibroid to adenomyosis in elastography, but it is not commonly used, and we will see the translational vascularization, and it can also diagnose malignancy in molecular level without there is any histopathological examination. So elastography can be used to diagnose malignancy. Now the accuracy of TBS and MRI for diagnosis of adenomyosis. TBS is 72% sensitive and specific is 81%. But in the other hand, MRI is sensitive 77% and specificity is 89%. So MRI is better than the TBS in diagnosing adenomyosis. Now the important topic, it is management of adenomyosis. So we can manage an adenomyotic patient in various conditions depending on women age, reproductive status, then clinical symptom, focal or diffuse type, then lifelong management, no fixed guideline, and there may be medical, surgical, and infertility treatment, and we can use one protocol alone, or there may be combination in case of management of adenomyosis. So first of all, we will discuss about the non-surgical management of adenomyosis. It includes medical and interventional. In medical, there is we can use non-steroidal anti-inflammatory drugs, non-hormonal, that is NSAIDs. Hormonal include oral contraceptive pill, then progestin. This may also include non-testosterone, then newer generation of progestin, that is Dynogest, then levonorgestrel into intrauterine system, and gonadotropin releasing hormone analog are the popular in management of adenomyosis. And there are also newer drugs that also help in managing adenomyosis, that includes aromatase inhibitors and specific progesterone receptor modulators. And interventional include uterine artery embolization and a high intensity focused ultrasound. And the surgical, if we treating the infertile patient who want to preserve her fertility, we will use uterus sparing surgery. And definitive surgery, if family is completed, multi-priority patient age is more than 40, her family is completed, she doesn't require or doesn't expect any issue, we will do hysterectomy. That is the definitive surgery for the adenomyosis. As we are talking the adenomyosis related to sub-fertility, that's why we will not discuss about the hysterectomy here. Just we will discuss the uterus sparing surgery and the medical management of the adenomyosis. Okay, first of all, non-hormonal, that includes non-steroidal anti-inflammatory drug. And what it does, it gives symptomatic relief, it reduces dysmenorrhea and produces anti-inflammatory effect. Thus, it helps in adenomyosis. Now, the most popular and first-line therapy for women with dysmenorrhea and abnormal uterine bleeding, we use combined oral contraceptive pills. And how it works? It works like producing anovulation, amenorrhea, reduce proliferation. It reduces the estrogen level, prostaglandin, and COX-2 level, and it acts inflammatory effect, and it's aided in reducing pain and producing anovulation and reduce proliferation. Now the progesterone or progestin, how it acts? Progesterone produces desensitization and atrophy of endometrial tissue. It also reduces the estrogen level, immunomodulatory effect and anti-inflammatory effect, and it has anti-angiogenic effect, and it inhibits the matrix metalloproteinase. Thus, it reduces the adenomyosis. Now the popular drug Dinogest, how it acts? It has both effect. One is central and another is local. How centrally act? It causes inhibition of the gonadotropin secretion and produce the hypoestrogenic environment with moderate suppression of circulating estradiol. It has ovarian function and ovulation. And locally, it acts like antiproliferative, anti-inflammatory, anti-angiogenic, and modulation of prostaglandin E2 expression. Now the levonorgestrel intrauterine system, how it acts? It releases 20 microgram of levonorgestrel per 24 hour in 5 years, and it causes desodalization of endometrium and adenomyotic deposit, and it thus causes reduced local prostaglandin production and abnormal uterine contractility, and it is also used in adenomyotic patient. Now another device, it is used only in Japan, and there are some research about using intrauterine device releasing danazol. We used 400 microgram of danazol in intrauterine device. It lasts for 6 months. It reduces dysmenorrhea, dyspareunia, and pelvic pain, and androgenic side effect is avoided. Now the popular analogs, that is GnRH analogs, mostly use GnRH agonist. How it works? GnRH agonist causes SERP to downregulate the pituitary. It has anti-proliferative effect. It reduces angiogenesis. It promotes anti-inflammatory effect and promote apoptosis of the adenomyotic foci. Okay, now the GnRH antagonist, most popular is elagolix. It is a newer modalities of drug. It causes suppression of reproductive function by inhibiting secretion of FSH and LH hormone, and it produces the hypoestrogenic condition. Now the newer drug, we used aromatase inhibitor and metformin. Aromatase inhibitors, this commonly that is letrozole, and this causes decreased conversion of androgen to estrogen, and it also causes regression of adenomyosis. Thus, it decreases the volume of adenomyotic tissue of the uterus along with GnRH, when it is used, it decreases volume and causes pain relief. And metformin, it inhibits growth of stromal cell, inhibits cell growth by activation of AMP protein kinase, that is AMP protein kinase is further used in activation of estrogen. The metformin inhibits growth of stromal cell. And levonorgestrel intrauterine system is better than oral contraceptive pill. It relieves dysmenorrhea and it produces amenorrhea in 6 months. Now the selective progesterone receptor modulators. Popular drug is asuprincil. It is progesterone receptor ligand with high degree of endometriosis selectivity. It inhibits endometrial proliferation. It suppresses prostaglandin production without estrogen deprivation. Dose may be 5, 10, 25 milligram for 5 weeks. We increase dose with the effect of disease reduction. Asuprincil can reduce dysmenorrhea even in minimal doses. Safety and tolerability is good and no adverse effect is reported. Now the figure as a whole, medical treatment management mechanism. Some are the GnRH inhibition, that are the GnRH agonists and antagonists. They work on hypothalamus and inhibit GnRH. And COP, that is combined oral contraceptive, danazole, and selective progesterone receptor modulators work on pituitary gland and inhibit FSH and LH hormone. Danazole can also work in ovarian steroidogenesis inhibition. Okay, we can use Dynogest, levonorgestrel intrauterine system, danazole intrauterine system, or device vaginal bromocriptine. This produces the antiproliferative effect on adenomyotic foci and endometrium. What does aromatase inhibitor do? It inhibits aromatase enzyme that causes the inhibit conversion of androgen into estradiol, thus decrease synthesis of estrogen. And how NSAIDs work? That block the COX-1 or 2 pathway, that conversion of arachidonic acid into the prostaglandin, prostacyclin, or thromboxane, and inhibition of inflammation and antioxidative stress action is inhibited by NSAIDs, and it relieves the pain during adenomyosis disease during menstruation. Okay, what are the advantages of this drug? These are the symptomatic relief only without any need of surgical treatment. As there is a drawback. What are these? Only temporary relief of symptom, but there is no permanent solution of the disease. Common side effects are producing amenorrhea, irregular bleeding, and menopausal symptoms like hot flash and then sweating, several postmenopausal symptoms. Okay, there are the some interventional modalities, that is uterine artery embolization. But if we want fertility, we will avoid uterine artery embolization, because if we do uterine artery embolization, there will be not implantation, there is a lack of supply through the uterine vessel. That's why if we want to restore the fertility, we will avoid uterine artery embolization. But for knowing purpose, I will discuss some about this. It is a major surgery. Then after 2 years, we may require 44% hysterectomy. In terms of fertility, it increases the complication of ovarian failure, amenorrhea, fistula, thus it causes the high miscarriage rate, increase IUGR, that is intrauterine growth restriction of the baby, preterm delivery, and postpartum hemorrhage. And it is not the suitable treatment with infertility. Okay, that is a figure showing the device for HIFU, that is MRI assisted high intensity focused ultrasound ablation. What it does, we use the ultrasound energy that induce thermal ablation at a given depth through the intact skin. Then histological changes are coagulation necrosis of the targeted localized adenomyosis and associated to vascular damage. A few cases of successful treatment of adenomyoectomy with adenomyosis with infertility have been published. So it is a modern modalities. It is used in several countries in case of treatment modalities of adenomyosis. Now the uterus sparing surgery. Uterus sparing surgery include adenomyoectomy that can be laparoscopic or hysteroscopic, and another is thermal ablation or adenomyolysis of the myometrium. Uterus sparing conservative surgery, there may be complete excision and partial excision. In complete excision, there may be done adenomyoectomy, cystectomy. Adenomyoectomy technique may be divided into classical and triple flap method. Classical, there may be modification that include overlapping flap and U-shaped suturing. In case of cystectomy, this includes classical technique. And cytoreductive surgery or partial excision, it is a technique or partial adenomyoectomy. The procedure may include classical technique, transverse edge incision, or resection, asymmetric dissection of the uterus. This figure showing the triple flap method of adenomyoectomy. Now in which patient we will done the uterus sparing surgery, or when we will do this uterus sparing surgery. First of all, younger infertile women who have failed medical treatment, concurrent adenomyosis with pain or menorrhagia, then older women with infertility despite ART, women with recurrent pregnancy loss or recurrent implantation failure, or well-defined adenomyomata if size is more than 5 cm in focal diseases. What are the results of adenomyoectomy? If we done adenomyoectomy, there may be 46% pregnancy rate increase, there may be relief of dysmenorrhea 81% and decreased menorrhagia about 50%. Now the important ART, that artificial reproductive technology protocol in case of adenomyosis. What may we have done in ART protocol? Consideration in ART, what we have done. First, we can do generous analog therapy before IVF. 2 to 3 months of generous agonist, that is leuprorelin acetate therapy, we can give for 2 to 4 months, that reduce uterine volume and improvement of embryo implant. We can do this before IVF, that is generous analog therapy. Then second, we can do stimulation protocol. Long generous analog therapy helps to induce decidualization of adenomyotic foci or tissue, that rendering the disease inactive. Okay, then the 2-stage IVF can be done. 2-stage embryo transfer is considered. First, ovarian stimulation, then oocyte retrieval and fertilization, followed by frozen thawed embryo transfer, that is FET at later stage. Then we can do single embryo transfer. Adenomyosis is associated with preeclampsia, second trimester abortion, preterm preterm delivery, and it is increase the risk of uterine rupture in multiple pregnancy. That's why you can do only single embryo transfer in case of adenomyosis disease. Then HRT, hormone replacement therapy protocol in frozen embryo transfer cycle, that is the clinical pregnancy implantation is higher in downregulation and HRT group, not than the if we do HRT and FET, then HRT alone group, the rate of implantation is higher if we do the downregulation. Now the uterine contractility and atosiban therapy. Atosiban is not routinely used for everyone. It also only acts on the selected group. It improves the afferent contractility and helps in uterine implantation. Now the another is mock embryo transfer. When we do mock embryo transfer, if there is an large uterus with distorted uterine cavity, then we do the mock embryo transfer. Okay, this all about the adenomyosis and its effect about infertility and how we manage, how we diagnose adenomyosis. Some take-home message for doctors, post-graduation doctors, gynecologists, infertilities that should keep in mind when they treat adenomyotic patients. That include adenomyosis is a clinically neglected condition. Okay, then understanding complicated by several factors like variable clinical presentation associated with other gynecological pathologies. That's why it's produced the diagnostic dilemma as it is presented with adenomyosis. PID may be present with adenomyosis. So it is understanding the several factor is important in diagnosis adenomyosis. Then we can take message that non-invasive diagnosis is possible, accurate without surgical intervention, but uniform diagnosis is still lacking. There is no single one diagnostic non-invasive diagnostic tool for diagnosis adenomyosis. Okay, management of women with adenomyosis associated subfertility is controversial. Why? Because overall lack of consensus regarding value of conservative surgery versus medical treatment to improve reproductive outcome. Then patient is with cytoreductive surgery has increased chances of antepartum or interpartum uterine rupture. There is more risk in diffuse adenomyosis surgery than focal surgery. Surgeon should be cognizant to balance between maximum cytoreduction and conserving adequate uterine tissue to minimize risks of adverse pregnancy outcome. Okay, there is increased adverse perinatal outcome including preterm birth, then premature rupture of membrane, PPH, spontaneous miscarriage. So we should keep in mind this regarding adenomyosis when we do cytoreductive surgery or uterus sparing surgery or give the management if we want to make patient fertile in case of diagnosis adenomyosis, and should be keep in mind about its effect and protocol. Thank you all. This all about adenomyosis and its effect on subfertility. Keep with learning, sharing, and stay with this channel for further updates. Thank you all. Assalamu alaikum.